This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. LaFredo, and this week, part 2 of my conversation with Dr. Alain Asher. He's the director of KRMC's cardiothoracic surgery program.
Diabetes and smoking are probably the most important factors in our region here. A well-controlled diabetic with blood sugars that are really strictly under good control can have a completely normal lifespan and spare all the vascular issues and neurological issues that the diabetics have.
I think of this sort of thing sometimes where, if you could take today's technology and visit, right, with one of your professors when you were a student, right?
It's one of my favorite fantasies.
Is that right? Mind blown, right?
Yeah, I'm going back a couple of hundred years with what I know now and reinvent everything.
Right. Well, so, that's a glimpse at where we've come from, and having witnessed these changes, where do you suppose your field is headed next?
It's pretty much assured that the field is headed towards much more less invasive procedures. Mm-hmm. Already over the last 10 years or even 15 years, we're making smaller incisions, we're repairing valves with small incisions, we're doing small incision bypass operations where 2 or 3 bypasses are necessary and in a certain area of the heart. But percutaneous therapies have come a long way. In coronary type disease, stenting and drug-eluting stenting, and there are some newer types of stents now that are the sort of the 4th or the 5th generation, where the stent itself will dissolve over time. That has made tremendous progress, so that most of coronary disease patients can be approached, at least initially, percutaneously. In terms of valve disease, we're 5 to 10 years behind what is done in Europe in terms of percutaneous valve replacements and repairs. But it's coming, and more trials are being done with less risk patients. Initially, take an example, aortic valve replacement, percutaneous aortic valve replacement with a stented balloon expandable valve that is placed essentially like a catheterization, going through the groin, advancing that, dilating the valve, placing the prosthesis there, which is stented, and then blowing up and expanding the stent so that it stays in place. Until very recently in the United States was reserved for very high-risk cases. You have to have 2 surgeons that say this is too high-risk a case to do as an open surgery, and the patient would be done better percutaneously to be allowed into a trial. Now there are trials for moderately high disease in the United States. In Europe, there are certain countries where percutaneous valve is offered as just another option. In standard, there are some trials for standard risk patients.
Why are we behind, or are they out into dangerous territory, or does that just depend on your interpretation of the situation?
It depends on interpretation, but in looking at the big picture and having experienced research and innovative technologies both in Europe and here, there is less regulation. Less regulation does offer less protection for the patient, but allows also for more risk-taking and earlier adoption of certain technologies. On the other hand, we are, in quotation marks, a little bit behind, but can offer a therapy to a patient after it's been shown in long-term studies to be effective. It's sure that people at the border will miss out because the technology is not readily proved yet in the United States for them. But I think in the big picture, 2 things are happening. The patients are safer here, mostly. But what's been happening in Europe is that more rigorous trials have been put into effect, so that although the technology is adopted earlier, their protocols have been very, very rigorous in terms of adopting the protocol, in terms of deciding who is appropriate for the study, and in terms of evaluating the short and long-term effects of the therapy. So that is increasing in Europe, and there's a bit of slowing down in terms of the rate of adaptation of new technology. In the United States, we've done sort of the opposite. There's some shortcuts now for valid and valuable therapies that can go on an accelerated track to be ready. And many of the newer valve repair technologies that'll be coming up and being used in the next year or two in the United States have gone through an accelerated track, but without losing that rigorous methodology to assure, safety for the patient.
When you consider these different procedures that we're talking about, the stenting and the valve replacement, the bypasses, are these all procedures that formerly would have had to be open heart surgery?
I would say so, yeah. Absolutely. There was very little percutaneous valve work done in the past until about 15 years ago, right, or even 10 years ago in the United States, and those were mainly balloon dilatations of stenotic valves, mostly in a much younger population, to allow them to grow to an adequate size for the prostheses we have. That applies in children, or also temporizing measures to allow the patient to grow old enough so that the valve that they get, because valves don't last, not all valves last forever, the appropriate valve will last for the rest of their life, right, essentially. So in the past, I agree with you, most of the operations were done, most of the procedures were done as open surgery. So there's less and less open surgery being done, and especially in valve technology, the surgeons are as much involved in the evolution of that as the cardiologists. And you were asking me before, what does the future look like? The future looks like a multidisciplinary team based on a heart team approach, where all the members of the team, whether the interventional radiologist, the cardiologist, or the surgeons, will be able to, on a team approach, in the same room together, be able to accomplish the procedure, no matter who the operator is. So as technology progresses, the skill set that each of the component physicians needs to have is getting closer and closer to each other. And in models like that, where a percutaneous valve program, which we're hoping to start here, it'll take us about 2 years to get running, any of the operators would be able to do the procedure. It's nice to have someone with slightly different experience, because in a tough situation, if access is a problem, for example, a surgeon might be better able to provide access for the device to get into the body. If placement of the device is critical, and a cardiologist has higher experience with tiny little wires and guides, may be able to contribute, and help the operator, whoever the operator is. And this is what cardiac procedures are going to be for sure within 10 years. I don't think you'll have cardiologists, surgeons, and interventional radiologists working independently. It'll be a team approach, and they'll all be doing the same thing. It'll be a cardiac or structural cardiac specialists.
You'll have a pilot and 6 co-pilots or something like that, or maybe just 6
Correct.
pilots.
And the pilots will change, will take turns. Right. I've gone to one of the places I go to experience new technology is in Leipzig in Germany. The Leipzig Heart Institute, which is headed by a surgeon, Fred Moore, as a matter of fact, are probably one of the 2 or 3 biggest pioneers in percutaneous valves. I was very impressed when I first visited about 8 years ago. There were 5 live cases, 5 live aortic valve percutaneous replacements. And there were several operators. There were 2 surgeons, 2 cardiologists, an interventional radiologist. And they lined them up so that, there would be a half-hour break between cases. Each case was done by a different specialist. The same exact procedure was done by the surgeons, then by the cardiologist, and by the interventional radiologist. and the whole team was there for the whole thing. And the team approach to procedures like that is so valuable because of the factors that we talked about before. The confidence factor, knowing that you have support and you can always ask, even if you don't get a definitive answer from the other person. Do you think we should do this or that? And it gives you confidence as you're doing that.
If there's anything I know about surgeons from having spoken with them over the years, is they tend to be a confident lot. They have to be. I mean, it's the very nature of their job that
Right.
they're going where they're like astronauts. They're going where the rest of us don't dare to go.
Well, to commit a surgical act, one has to have assurance that what I'm doing now is the right thing.
Yeah.
Whether we're right or wrong, we have to believe that what we're doing is the right thing. We'll find out later on sometimes whether what we did was right. But there is a degree of confidence that's necessary for the surgical act. But even in a surgical operating room, the most valuable person for the surgeon is the assistant. And the assistant is not someone who just, here, hold this or pull on this and that sort of thing. But the assistant is a true partner. We recently acquired a former surgical assistant of mine from another institution. And it is amazing the value that person brings, because let's say you're doing a valve. Should we put in a 27 or a 29? And you ask that question. Well, the 29 fits. I've been there where the 29 fits, but it was too hard to close the aorta after that. There's some experience. And also a team experience develops when there are more than one individuals. Right. So that the members of the team are not just performing some specific physical duties. They're helping in real-time decision-making and remind the surgeon of the group experience. Hey, last time you did this, we got in trouble with that. How about if we try this instead? Right. That kind of thing.
It's time for a quick break on Focus on Your Health. We'll be back in just a moment for more with Dr. Alain Asher. Stick around. And welcome back to Focus on Your Health. I'm TG LaFredo, and this week is part 2 of my conversation with Dr. Alain Asher. He's the director of KRMC's cardiothoracic surgery program. Early on, you were talking about the older patients with coronary disease. Is that the right term for it?
Yeah.
And you were saying what I was gathering was, when you go in to do those surgeries, you are witness to. The term you used was abuse. They've sort of abused themselves, many of them, over the course of their lives. Yeah.
Or life has abused them.
Or life has abused them.
As we get older, we wear out.
Yeah.
Smoking, for example, is one of the biggest factors in coronary disease. Somebody who's older has smoked for a lot longer than somebody who's younger. If we have a 50-year-old who smoked for 30 years, as opposed to a 70-year-old who smoked since they were 16. Oof. There's a cumulative effect of those nefarious, influences. People who don't exercise, which is also a big risk factor. Sedentary lifestyle is a big factor. Well, if you haven't exercised in 40 years as opposed to you haven't exercised in 20 years, there's a big difference in the two types of patients. We have, fortunately, some patients in this particular environment who are older but who have kept in shape. There's some very active older patients, and sometimes it's less risky to operate on an 85-year-old man or woman because they've survived till 85, because they've exercised and kept in shape.
It verges on a personal question, but knowing what you do about those lifestyle decisions and what they do to your insides. It had to, I mean, you learned that early on in your life. It had to have I'm guessing, it had to have a powerful effect on you and your personal
myself?
life. Yeah, I mean, on the decisions you made and the life you led.
I think so. Well, fortunately, I think I've led a pretty healthy life. I'm pretty active. I engage in a lot of physical activities. I'm European originally, so I follow the Mediterranean diet just by nature, which is
fewer cheeseburgers.
Portions.
Is that
sorry?
Fewer cheeseburgers?
Yeah, fewer cheeseburgers is the answer. It's not no cheeseburgers, and that's the key. Diet is and has become a more and more important factor. Leaving obesity aside, of course, which is something of an American phenomenon, especially. But obesity obviously can be treated with exercise and modification of diet. But patients always ask me, okay, what can I eat now that I have my coronary bypass operation? And the true answer, and the new guidelines coming out from the Food and Drug Administration and the American Heart Association have reversed everything that was imprisoning patients in the past. You'll see over the next months, certainly less than a year, that the old skim milk, no butter, no fat diets for cardiac patients are going to go by the wayside.
Is that right?
They create more stress on the individual than a healthy whole food type diet. So butter is okay, eggs are okay again, meat is okay, but in moderation.
Yeah.
And I mean, the typical healthy diet, which we've seen in countries that have very low incidence of coronary disease, such as Southern Europe, France, Spain, Italy, is a diet where people eat everything. Yeah. They don't eat the quantities that we eat here, and they don't eat as much processed products as we do. So getting away from processed foods, eating whole foods, a little bit of fat on a steak is okay, but you don't need to have the giant,
the 42-ounce,
the quarter-pounder hamburger in Europe is a tiny little thing,
Yeah. Gosh, yeah.
So you're asking me about, did that reflect on my personal?
Yeah.
So personally, I'm in a low-risk category because of my own personal activities. But I've seen surgeons have to think about this, and unfortunately, as happens a lot in many other professions or activities, when you're in it, you think that you're sort of immune. I'm a heart surgeon. I'm never going to get coronary disease. The auto mechanic has a car that is running on its last legs all the time. I think dentists do pretty well. They break the rules and they have excellent teeth. But there is a feeling of protection because I'm in the field, which is not true at all.
Right.
And you'll see that most, at least the younger heart surgeons, the newer generations in the last 15 years or so of heart surgeons are very, very healthy people.
Yeah.
They eat healthily, they're not obese, they have muscle mass.
It's a way of life.
And it becomes a way of life, yeah. I mean, it's so obvious, it's so logical.
Sure.
I remember when I first trained in cardiac surgery, not only was smoking a lot in the hospital, the surgeons would be smoking at the scrub sink as they're scrubbing, which is unheard of nowadays.
Yeah. Oh my gosh. Well, is there anything else that I'm forgetting that we should put in?
There is one thing that is, I think, important to get a patient through any kind of procedure. Two extremely important things. Number one, understanding what's going on, being a participant, being a partner in not only the understanding of the disease process, but in the decision making. It's always associated with better satisfaction and much, much, much better outcomes. The other one is support. Physician support from the individual's primary care physician, and as important, if not even more important, family support. And that works both ways. There are patients say, I don't want my family to know, I don't want them to come, et cetera, et cetera. It's a mistake. You can't fight that fight alone and be guaranteed that you have a good outcome. So not only psychologically, but in terms of support during decision-making, one of the most typical things that happens after patients leave a doctor's office, if they have somebody with them, is, now what did he or she say about this? Did I understand this right? And that brings me to the third component, is don't hesitate to call back and ask the questions that you need an answer to, because under the pressure of being in and this is something we pay attention to a lot in this office. We spend a lot of time with our patients, whether it's in the office or mostly in the hospital, making them feel secure that they can ask the questions, and that if they didn't ask you during that particular period of time, we encourage them and we want them to feel comfortable that next time they see you, hey, I didn't understand this. Can you do it again? Or can I ask you a question about that? It is such an important process, because the process has been shown by many, many studies to yield better outcomes. The patients do better. They feel better, they're more confident, and that has a psychological effect that is immeasurable. The relationship between the patients and the physicians, especially in a procedural sort of enterprise, also yield enormous outcome. Patients always do better when they're A, confident, and B, communicative with their physicians. So asking questions and family support.
I recommend carrying microphones and recording equipment everywhere.
Yeah.
Then you catch what the doctor
I think that's a
says.
professional sort of thing. Very rarely, people do come in and either discreetly or in the open and turn on their phone or want to record this. For most physicians, it makes them uncomfortable.
I noticed.
and I don't think it's in a medical legal way, but it makes physicians a little suspicious.
For me, I would assume it's a litigious society. I would assume that would be why.
Right. And even if one does not think that, okay, they're doing this for eventual, litigation, it just makes you behave differently. Reality TV, one of my favorite nemesis.
An oxymoron.
Yeah, exactly. The Heisenberg uncertainty principle. You are modifying the experiment by the fact that you're introducing.
Of course.
So you're not really yourself.
You're also, when you have producers telling you what to do.
For sure. Yeah, no, that's for sure. But I think when you're put on the spot like that, even here we are, we're talking. Mm-hmm. The talented interviewer will make their subject so comfortable that they can very quickly in the conversation go into the free mode, the freestyle mode, the true self. The true opinions are going to come out. The true advice is going to come out, as opposed to being on edge and trying to put on an act to either impress or not to get in trouble. Right. Or not to say something stupid.
Yeah, that doesn't make for very good radio.
Not at all. And that is a talent that you certainly exhibit.
Oh, shucks. Well,
I'm serious.
I thought you were just giving me notes for the future. That's Dr. Alain Asher. He's the director of KRMC's cardiothoracic surgery program. Dr. Asher, thanks so much.
That's my pleasure.
And that's the show. I'm TG LaFredo. Thanks so much for listening. If you'd like to send me an email, you can write to me at foyhradio@gmail.com. That's Focus on Your Health, foyhradio@gmail.com. We'll catch you next time.